I think we are here for a session on coronary intervention, and I would like to introduce panelists Tan, Hussain, Ajima, and Kawan. Your first speaker is Jian Chen Lim. He'll be speaking on AVR ST elevation myocardial infarction, a not so urgent cardiac emergency, a single tertiary center experience in Malaysia.
A very good afternoon to the esteemed panelists and my fellow colleagues. My name is Jian Chen Lim, a cardiologist in training hailing from Malaysia. The topic of my presentation today is AVR ST elevation MI, a not so urgent cardiac emergency, a single tertiary center experience in Malaysia, and nothing to disclose. Allow me to give you some background information regarding the hospital where the study was done. Hospital Raja Permaisuri Bainu is in Ipoh City, the capital of state of Perak in Malaysia. This is the state with population of 2.5 million. However, HRBB is the only public hospital which provides cardiology service in the whole state. Thrombolysis is still the preferred method of STEMI reperfusion instead of primary PCI due to limited cath lab and manpower. In fact, we only have one functional cath lab in the entire hospital. In addition, there's no in-house cardiothoracic service. The nearest public cardiothoracic centers are in other states, which are about 2 hours away by car. This is a picture of my hospital, even though it looks pretty, but we have very limited resources. So AVR STEMI is well recognized as a sign of acute occlusion of the left main or proximal LED. However, not many studies have been done on it, hence we are not sure whether AVR STEMI is always associated with acute thrombotic coronary occlusion. In addition, due to the limited studies, best acute management is not well defined. To address these concerns, we decided to investigate the incidence of an acute total occlusion in culprit coronary vessel in patients presenting with AVR STEMI. We also look at 3 months clinical outcome of these patients, and in the process to determine whether there's a need for immediate coronary angiogram with reperfusion. This study was done in a retrospective manner in a single center where all AVR STEMI admissions between January 2018 and January 2020 were included. All the ECGs and coronary angiograms were analyzed by experienced cardiologists, and we define AVR STEMI as patients presenting with typical acute chest pain with ST elevation in lead AVR more than 1 nm. ST elevation in lead AVR must be taller than ST segment in V1, and also the presence of widespread horizontal ST depression in other leads. This is the example of AVR STEMI. So out of 1,147 STEMI admissions in study period, we only were able to identify 32 of them who had AVR STEMI. All these patients has undergone coronary angiography during index admission, but none were thrombolized. These are the patient characteristics. As you can see, most of the patients are above the age of 60. They are predominantly male, and most of them have hypertension and diabetes. We did not find any patient with acute total occlusion in these 32 patients with AVR STEMI. However, we did find 14 patients with chronic total occlusion, which I'll explain in my later slide in discussion. Out of this patient, around 70+% of them have triple vessel disease, either with left main or without left main involvement. And this pie chart depicts the types of revascularization that these patients received within 3 months of follow-up. As you can see, only 9 patients were successfully revascularized, 3 by the means of PCI during index admission, 6 of them by the means of CABG. 7 patients were put on optical medical therapy. 3 unfortunately passed away, and 6 of them were still awaiting for revascularization by the end of 3 months period. 7 were lost to follow-up. The mean waiting time for CABG was 60.3 days. Out of the 7 patients in optical medical therapy, 4 were actually offered CABG, but they refused due to various reasons. The other 3, one of them was deemed not suitable for CABG. 1 had very poor ejection fraction with non-viable myocardium. 1 patient had only moderate coronary artery disease. Out of the 7 patients in lost to follow-up, 6 were offered outpatient CABG, and 1 was referred to CTC in another center during index admission as inpatient. And out of the awaiting revascularization group, 5 were awaiting outpatient CABG, 1 was awaiting 4-stage PCI to osteoartery CTO. As you can see, those patients with left mean-stem remodeling were having the most trouble. In fact, 3 of them actually passed away, and none of these patients who has passed away received any form of revascularization. So, most people, when interpret ECG, they tend to ignore the lead AVR. However, it has risen in popularity recently due to its association with left mean-stem disease or osteo/proximal LAD disease. It has also been associated with severe triple vessel disease. However, due to limited studies, most likely due to the fact that it's actually quite rare, as shown in our sample size, incidence of each is actually not well defined. Our study actually showed 0 incidence of acute total occlusion. However, there were 14 patients who were identified to have chronic total occlusion, and they were differentiated from the acute ones by the presence of collaterals from other coronary vessels. As mentioned previously, 78% of the patients had 3VD with or without left mean-stem involvement. Hence, many of these patients may not be appropriate candidates for emergent catheterization, especially at night during on-call. So early CABG is actually recommended, especially for those with left mean involvement. And the mortality for left mean-stem disease is definitely higher than those without left mean-stem disease. Those patients were still alive those patients who received revascularization, they were alive within 3 months post-angiogram. However, there are some limitations to my study. Number 1, this study was only done in 1 center, and the sample size was very small, only 32 patients. Unfortunately, we had to cut short of the follow-up time due to the raging pandemic, and many patients were lost to follow-up beyond 3 months because they were referred to other centers. In conclusion, AVR stenting was not associated with acute thrombotic coronary occlusion in our study population, and thrombolysis or primary PCI may not be indicated for this group of patients. However, early catheterization is definitely recommended, although might not be within 24 hours from admission. Mortality is definitely higher for patients with significant left mean disease. And this study actually helped us to do 3 stratification on which type of cases that need emergent catheterization, particularly in a center with limited resources like mine. That's all for my presentation. Thank you.
Thank you, Dr. Ling. It was a nice presentation depicting that whenever we find elevation of AVR in ECG, be cautious because these are the patient subset which is going to be serious, and we have to act very promptly to see. As you have seen in your study, surprisingly, we have not seen any patients with the fresh total occlusion, but clinically we see patients with the AVR elevation which have, even I have seen left main total occlusion, fresh total occlusion, patients presenting with the AVR elevation might be having this severe ST depression in all the leads along with the AVR elevation. Any comments from the panelists? Then we can move forward.
Thank you. Thank you, Mr. Lim, for your nice presentation. The most of the patients with ST elevation in AVR, those who are stable, the patients are included in your study, possibly those who are stable. But in patients, while admitting a patient with in a setting of acute coronary syndrome with AVR STF, the patient mostly are unstable, and most of the patients in hospital death is very high before reaching into hospital and in hospital. Those who are included in this study, I think the results are very promising. That is, those who are stable patients, gone for coronary angiogram check. But most of the patients are very unstable, those who are not included in this study. I think all the patients are not also indicated in early coronary intervention also. Thank you for your intervention, presentation.
Thank you. Actually, may I add, actually one of the patients actually passed away during index admission. So some of the patients were actually unstable. But somehow we did not find any patient with acute total occlusion. But of course, our sample size is very small, hence the limitation for the study. Thank you.
May I have a comment?
Yeah, any other comment, please? Yeah.
Dr. Lim's a very interesting study. So may I ask, any patient in your cohort, they are presented with cardiogenic shock? Because if it's transient left main occlusion or transient AVR with stem, left main occlusion, the patient may be very sick and also may be presented with a very unstable hemodynamics. So any patient in your cohort that did have a cardiogenic shock or actually not respond to thrombolysis?
Okay, thank you for the question. There was one patient who presented with cardiogenic shock, and all these patients, they did not receive any form of thrombolysis. And that patient, I mentioned just now, passed away, but he was not having total occlusion as well. In fact, he had 3VD, triple vessel disease with left main stem involvement, but which was not total occlusion. But yeah.
Yeah, I guess the ST elevation over AVR and also widespread ST depression, the only, the most important, meaning is patient have a quite bad severe coronary artery disease.
Yeah, one thing I want to make here that these patients actually might not present as ST elevation, but when you do enzymes in these patients, TROP-I in these patients, most of these patients will be positive for that. Maybe the patient is not presenting totally as a subset of ST elevation, but ST elevation MI. But if you find TROP-I, I think you have not studied cardiac enzymes in your study, and most of the patients are critical, behaving like acute myocardial infarction. So yeah. Any other? Yeah.
Okay. Actually, most of the patients, they referred to us. The cardiac enzyme were raised actually, but not all of them had markedly raised to the. Some of them were just slightly raised, and some of them had CKD. Hence, the cardiac enzymes might be falsely raised as well in CKD patient. But I do agree with you. Most of the AVR STEMI in other studies present, the way they present is very acute and very ill. So my sample of patients, they are rather stable compared to other study populations.
Yeah, and another thing I have noticed in these type of patients, they have high incidence of sudden cardiac death. The patients, as you showed, some of the patients were not revascularized, and these are the subset of the patients who eventually will have sudden cardiac death. And some of the patients with AVR elevation already present with cardiac arrest in clinical scenario. post-cardiac arrest, post-cardiac arrest patients having AVR elevation. I've seen quite frequently.
Yes, definitely. But like I mentioned just now,
so I think with the restraint of the time, we go to the next topic. I think Dr. Risberg will be presenting last. So I would invite Dr. Shekhar Roy. The presentation is utility of Grace and TIMI risk scores to predict coronary revascularization in patients with non-ST elevation acute coronary syndrome. I would invite Dr. Shekhar Roy.
So respected moderators and panelists and respected participants, good day. I am Dr. Sharadindu Shekhar Roy from National Institute of Cardiovascular Diseases, Dhaka, Bangladesh. Would like to welcome you to my original research article presentation. It is titled as Utility of Grace and TIMI Risk Scores to Predict Coronary Revascularization in Patients with Non-ST Elevation Acute Coronary Syndrome. Acute coronary syndrome is an operational term for the conditions of acute myocardial ischemia and or infarction, and the absence of persistent ST segment elevation in the setting of acute coronary syndrome is non-ST elevation acute coronary syndrome. This is a diagrammatic picture to show the two arms of the acute coronary syndrome. One is ST elevation myocardial infarction, another one is non-ST elevation acute coronary syndrome. The guidelines recognize the importance of early risk stratification in the management of a non-ST elevation acute coronary syndrome. Their class 1 recommendation is use risk scores to assess prognosis in patients with non-ST elevation acute coronary syndrome. And they say that the risk stratification models can be useful in managements. Their recommendation is early invasive studies in high-risk group of patients and selective invasive with non-invasive testing in the intermediate and low-risk groups. But what are the ways to risk stratification? There are several risk scores, among them TIMI risk score and the GRACE risk scores are focused by the guidelines. And these are the clinical parameters to calculate the GRACE and TIMI risk scores, and both the scores can easily be calculated through web-based calculator. But which one is superior? GRACE score provides the most accurate in stratification of ischemic risk and risk of mortality, and the TIMI risk score is simple to use, but its discriminative accuracy is inferior to GRACE score. Actually, the GRACE and TIMI risk scores calculate the patient's risk of mortality and risk of recurrent ischemic event. But our question was that, are they able to predict the need for coronary revascularization before angiography? If so, which one is superior to predict coronary revascularization? To sort out these questions, this cross-sectional study was done in the Department of Cardiology, National Institute of Cardiovascular Diseases, Dhaka, Bangladesh. From April 2017 to March 2019, total 315 patients are studied, and patients with non-ST elevation acute coronary syndrome who agreed to undergo coronary angiography during index hospitalization are included, and patients with history of previous MI, PCI, or CABG are excluded. All patients were evaluated clinically at the first presentation. 12-day ECG, cardiac troponin I, serum creatinine, and blood sugar were assessed during admission. At the time, the GRACE and TIMI risk scores were calculated using web-based calculator. The patients are divided into low, intermediate, and high-risk groups according to GRACE and TIMI risk scores, and coronary angiogram was done during index hospitalization. The need for coronary vascularization was assessed through angiographic characteristics by means of vessel score. And the patients were categorized as no vessel involved, single vessel diseased patient, double vessel diseased patient, and triple vessel diseased patients. What we found in our result, more patients were found in the high GRACE score group and more patients were found in intermediate TIMI score group. And this table showing the distribution of the study population according to the vessel score to assess the patients who warrant revascularization. And we got much more patients who warrant revascularization, and it was 84.8% who warrants revascularization. And both mean GRACE and mean TIMI score are high in patients who need coronary revascularization. And Spearman's rank correlation test was done, and it is the result, and this test was done to assess the need for coronary revascularization for both the scores. We have got correlation coefficient for the GRACE score was 0.64, and for the TIMI score, it was found in 0.5. And both the correlation coefficient was statistically significant for the positive correlation. And finally, we plotted a receiver operator characteristic curve for the scores, and area under the curve for the GRACE score was found 0.821, and area under the curve for TIMI score was found 0.759, and the difference between two area under curve for was found 0.062, which was statistically significant for the superiority of the GRACE score. And the cutoff for the GRACE score to predict the need for coronary revascularization was 123.5 with a sensitivity of 77% and a specificity of 51.8%. And the cutoff to predict the need for coronary revascularization was 2.8 in case of TIMI score with a sensitivity of 68% and a specificity of 39.1%. In conclusion, our study demonstrated both GRACE and TIMI scores had good predictive accuracy in assessment the need for coronary revascularization in patients with non-ST elevation acute coronary syndrome, but when they were compared, the GRACE score was found to be superior to the TIMI score. We discussed in non-ST elevation acute coronary syndrome, a risk stratification model would be a valuable tool for the severity of coronary artery disease that warrants revascularization. And in predicting coronary revascularization, the superiority of the GRACE score explained by several features such as heart rate, systolic blood pressure, serum creatinine, heart failure class, and presence of cardiac arrest over the TIMI score. So our recommendation is the GRACE score can be used with an evidence of more strength than the TIMI score to predict coronary vascularization in patients with non-ST elevation acute coronary syndrome. Thank you, sir. Thank you very much for patient hearing.
Thank you very much. It was a nice presentation comparing the two scores. The commonly found patients in our clinical practice of non-ST elevation MI, we are in dilemma that we have to treat these patients very quickly like ST elevation MI, or we can wait for another 4 hours, 12 hours, 24 hours. And these scores definitely help us to predict which patients need the most urgent revascularization. And as in your study, you have told that the GRACE score slightly predicts more. Prediction is more valuable GRACE score than the TIMI score. Any comments from the panelists? Any questions we can?
Thank you, Mr. Sharadendra, for your very nice presentation that come in consideration for revascularization also. That was initially started for the early mortality study in patients with non-ST elevated myocardial infarction or acute coronary syndrome, where the risk stratifications for early intervention, the most widely used was the GRACE score earlier than the TIMI score. So it's a very nice presentations and recommendations is very nice for better the TIMI risk score over the GRACE score. So for very nice presentation, I think it can be used in further long-term further multi-center study also, and might become an further hope to see in further guidelines also. Thank you for your
thank you, sir. Thank you very much, sir.
So, yeah, thank you. Very nice presentations. So I just want to ask, will there be any bearing in terms of the score? If you have a higher score patient, will you be benefit from early intervention? Have you ever, further analyzed your data?
Sir, please, sir.
If the patient have higher score, will they be benefit from earlier, let's say less than 24 hours for the revascularization? So will there be any difference in terms of the
Sir, thank you, sir. Thank you for your questions. We have done this scoring within 24 hours of admission, and within 24 hours of admission, we have got all the parameters to calculate the GRACE and TIMI scores, and after admission, and from the time onset, we have tried to calculate the GRACE and TIMI scores within the 24 hours of the time onset of the study population, sir. Thank you.
Yes, but will there be any difference if the score is higher, let's say more than 140 for the GRACE score? Will they be, have an early, revascularization? Will this patient doing better? Do you have any further analysis on your data?
Sir?
His question is that any further analysis on your data which shows that we should take this patient early with this higher score?
No, sir. We have got the earliest course, and we just assessed the warrant of revascularization. The patients were assessed to need for coronary revascularization, and those patients underwent PCI or CABG. We have followed up, but not we could not follow up all the patients who underwent revascularization, but we assessed during angiography who needs coronary revascularization.
Means angiographically, the results were in favor of urgency in the patients who had a higher score.
Patients who had higher scores.
Yeah, with the higher gray score or higher TIMI score.
We have got the higher grace and higher TIMI score. Those patients were not actually underwent revascularization or kept on medical management. We excluded from the study. Excluded, sir. Thank you, sir.
Thank you, Dr. Shekhar Roy, for your nice discussion and presentation. I would invite next speaker for the study, that is acute and midterm results of percutaneous coronary intervention of severely calcified coronary artery lesions with orbital atherectomy system. So this is I would invite Dr. Koike to please from Japan. Can you kindly come and start with your presentation?
I'm Junpei Koike from Qca Hospital, Japan. I would like to talk about acute and midterm result of PCI with OAS. This is my COI. PCI to severe calcified regions are associated with lower procedure success rates and higher rates of target vessel failure. Scoring balloon and rotational atherectomies are applied to modify the regions. However, PCI to these regions still result in worse clinical outcomes. Diamondback orbital atherectomy system (OAS) is a novel device to prepare severe calcified regions. It uses centrifugal force and differential sanding to reduce the calcium plaque. We assess the clinical outcomes after OAS of severe calcified regions. 539 regions, which were underwent PCI with OAS in Kyoto Hospital from February 2018 to December 2021, were enrolled. We evaluated the procedure success, angiographic complications, in-hospital MACE, and midterm result. So let's move on to the result of this study. At first, this slide shows the patient characteristics. Average age was 76 years old. 74% of all cases was male. 39% of patients had CKD, and 14% were hemodialysis patients. Next slide shows vessel and region characteristics. LAD region was the most common in 52%. The rate of RCA was 25%. De novo regions and in-stent regions rate was 84% and 7%. Procedure data is shown in this slide. We can use only classic crown now. In all cases, we use an imaging device, OFDI OCT, and IVAS in about half each. We performed OAS at low revolution speed in all regions. Since further ablation was required in 65% regions, we did an additional ablation in high revolution speed. We also used rotational atherectomy in 12% of regions, when OAS could not pass the regions, and region needed additional ablation. Regarding final device, 84% of the regions were additionally treated with drug-coated balloon, and stents were implanted in 14% of regions. This is QCA data. Percent diameter stenosis changed from 56% to 20%. We could get 1.05 mm of acute gain. This slide shows in hospital outcomes, procedure success rate was 96%. On angiographic complications, coronary perforations occurred in 1% of regions, and transient slow flow in 17%, and persistent slow flow in 3% of regions. In hospital MACE occurred in 10%, with cardiac death occurring in one case, the procedure MI in 10%, there were no TVF. Then we evaluated the midterm clinical outcomes of 417 regions, 327 cases. We performed PCI more than 8 months ago. We could perform follow-up angiogram in 292 regions. Angiographic follow-up rate was 70%. This slide shows midterm clinical outcomes. Post-discharge MACE occurred in 17%, with cardiac death occurring in 3%, the TLR in 8%, TVF in 14% of cases. In follow-up angiography, restenosis rate was 9%. When we evaluated the restenosis rate for each final device, restenosis rates for the region treated with DCB was 11%, and that with stents was 2%. Lumen diameter stenosis was 27%. Rate lumen loss was 0.17 mm. Rate lumen enlargement rate was 37%. So let's summarize this study. Procedure success rate was 96%. Persistent slow flow occurred in 3% of regions, and the hospital MACE in 10% of the cases. In a large proportion of regions treated by DCB, restenosis rate of 9% was acceptable. 12% of the regions required additional treatment with rotational atherectomy, because OAS alone was insufficient for ablation. We need more consideration which cases are suitable for OAS. This is conclusion. Thank you for your kind attention.
Thank you, Dr. Koike. This was a nice study to demonstrate that calcium modification before in a calcified lesions before we revascularize is a very important aspect of our treatment. With the many treatment modalities available, we are not still very clear that which modalities to be used when. Even when we have subsets of imaging with us, we are not very clear that suppose there is a calcified nodule, there is a superficial calcium, deep calcium, or there is some eccentric calcium, there is a large vessel, there is a bifurcation lesion. There is a CTO associated with the calcified lesion. All these are the subsets where we need to do further research and see which type of calcifying modification will help in which patients more. Recently, the data from Disrupt-3 has shown that the newly evolved calcifying modifying these things have IVL has been used in all comers, and there are very good picture coming. The MACE in your study was about 10% in hospital MACE, and I think with IVL there were lesser complications and lesser flow, but this needs further clarification. The head-to-head trial with the with or without modifying agent, calcium modifying devices, and with or with IVL, with orbital and rotational. Any other comments from other panelists? Any questions? Please.
Yes.
Right.
Yeah. Hi, I'm Osongwon from South Korea. Thank you for your very nice presentation and results, and it's very interesting. But I wonder, you used the TCB after orbital atherectomy more than 80%. So do you have any reason to prefer TCB rather than stent after orbital system?
Thank you. We use TCB more stent, and for example, large vessel, we use stent often. However, small vessel or calcified nodule lesions, we use TCB because calcium plaque made restenosis outside of the stent. If we put the stent to the region, we cannot revascularization made so difficult. So
actually, it will be an interesting study to see. Most of the time we would tend to implant a drug-eluting stent in our patients after modifying the drug, but it will be definitely an interesting study to see what the drug the patients treated with drug-eluting balloon, drug-coated balloon, versus the patients who were put on stents. That would be definitely an interesting study, because most of the complications post MI, are they reduced with drug coating balloon when it is used alone? So this is a point to ponder and to be studied in future. Any other comments?
But it's still there. Thank you for his nice presentation. But still there is no recommendation where the drug coated balloon is found to be more patency over the drug-eluting stent. So most of the patients where the orbital atherectomy is done, but still left for only treated by DCB, if it is feasible to put a stent, that is, I think the newer study, as you have mentioned, the new study will be very helpful, where the follow-up of the patients for drug-coated balloon either is a good result over the stent. I think.
Yeah, I totally agree. I totally agree with the opinion. Yeah.
Thank you.
So I think with this, we can move on to the next session. The next session is the peri-procedural myocardial infarction or injury in novel low-speed following high-speed and conventional high-speed rotational atherectomy technique for heavily calcified coronary artery lesions, the Primo Rota pilot study. I think the presenter is Dr. Mahesh Gurung from Thailand. I invite him to present his study.
Good afternoon, everyone. I'm Dr. Mahesh Gurung from Police General Hospital, Thailand. It's an honor to present my research on Primo Rota pilot study, periprocedural myocardial infarction or injury in novel low speed following high speed versus conventional high speed rotational atherectomy technique for heavily calcified coronary artery lesions. Do not have any potential conflict of interest. Rotational atherectomy technique has evolved over the years, and concept of plaque modification rather than debulking has led to the best current practice recommendation as shown, which in turn has markedly decreased the traditional associated complications. However, even in the era of drug-eluting stent, the complications still occur, and focusing on periprocedural myocardial infarction, the incidence range from 1 to 20%. The substantial difference in the incidence is attributed to the heterogeneity in the definitions used and varying operating experience and evolution of the technique. Nonetheless, the prognostic implication of the periprocedural myocardial infarction has been consistent in various studies as an independent predictor of one-year mortality and fourfold high risk in post-PCI MACE. The major mechanisms relate to distal embolization, platelet activation, and thrombosis, leading to microvascular plugging. The prior studies have shown that higher the speed of rotational atherectomy leads to more severe platelet aggregation. Therefore, the recommendations on speed has changed over time from conventional high speed to lower and safer range up to 135,000 RPM. More recent studies have even shown lower range as low as 110,000 RPM. In this recent study published in May 2019 showed that novel technique of combining high speed and low speed rotational atherectomy could achieve larger lumen without increase in complication of periprocedural myocardial infarction, but this was a retrospective non-randomized study. In comparing the pros and cons, although high speed causes less friction, therefore makes it easier to navigate to the distal vessel, but higher thrombotic complications occur. Lower speed causes less platelet aggregation and thrombotic complication. At the same time, it may be difficult to pass the burr to distal vessel and longer procedural time. With this background, our study was focused to compare the incidence of periprocedural myocardial infarction between the novel rotational atherectomy technique, combination of high and low speed, and conventional high-speed rotational atherectomy technique. The secondary objectives were to compare the incidence of in-hospital outcome, post-rotational luminal gain, and optimal stent results. Fourth universal definition of periprocedural myocardial infarction was used, which requires 5-fold increase in troponin T along with either ECG change or angiographic findings of no flow, no reflow, side branch loss, etc., and isolated elevated cardiac enzyme without other features were considered as periprocedural myocardial injury. This is a prospective observational single-center study conducted from January 2019 to May 2021, and standard indication for rotational atherectomy was used to include and exclude the cases using clinical and angiographic criteria. All rotational atherectomy cases were divided into 2 arms, and 1.5 millimeter burr was used for all cases. This is a representative case using OCT, coronary angiogram co-registry, and MLD assessment using QCA for pre, post, and final stent results. The risk difference of periprocedural myocardial infarction in 2 groups were identified using multivariable binomial regression analysis. Total of 21 cases underwent rotational atherectomy during the study period. 9 were excluded, and final 6 patients in each group were included in the study. Baseline characteristics were similar in both groups in regards to age, gender, and underlying conditions and medication. LAD was the common target vessel. Femoral approach was preferred in both groups. Larger guiding catheter was used in novel technique, and longer total runtime in novel technique was noted, however, statistically insignificant. Though there was no significant difference in terms of pre-post dilatation balloon use, novel technique resulted in larger diameter stents and post-dilatation balloon. Overall stent length or lesion length was relatively long in this study. 17% of the study patients developed periprocedural myocardial infarction, all of which occurred in the conventional technique arm. Nevertheless, similar cumulative incidence of infarction or injury was seen in both groups. Multivariable binomial regression analysis was performed to identify the risk difference of periprocedural myocardial infarction between 2 study groups, and potential confounders based on previous studies were included in the final model. And statistically, it could be demonstrated that the novel technique significantly reduced the risk of periprocedural myocardial infarction or injury by 55%. Compared to the conventional technique, there was trend to achieve larger immediate post-rotational luminal diameter in the novel technique with adjusted mean difference of 0.35 millimeter. The similar complications of slow flow was observed in each group. Rest of the complications did not occur. Optimal stents results were similar without statistical significance. To our knowledge, this is the first of its kind to compare the incidence of periprocedural myocardial infarction between two rotational atherectomy technique. There are some limitations to our study, as it is a single-centered observational study with very small sample size, and operation influence bias on preference and experience could not be controlled, and use of 2D QCA has its own limitation. In conclusion, periprocedural myocardial infarction or injury is common, yet under-addressed. The novel rotational atherectomy technique can significantly reduce the risk of periprocedural myocardial infarction or injury in heavily calcified coronary artery lesions. There was trend towards large post-rotational atherectomy MLD in the novel technique arm. Further RCTs with larger sample size are needed to confirm these findings and its clinical impact on the follow-up MACE. I'd like to thank my advisors and colleagues, and that's the end of my presentation. Thank you.
Thank you very much for this presentation, and it was a nice depiction that how the technique can change our maybe short-term outcome, and maybe the technique we use, we can have different scenario of developing MACE during the procedure. I think with the newer modality coming, the MACE rate is definitely reduced, and we can be very selective in our cases where to use rotational, where to use orbital, or that needs a long-term evaluation of these devices. And with this, any further comments from our panelists or any questions?
Yeah, very elegant study. So I just want to know, is it really necessary to go for low speed and then high speed? Can it just low speed will be okay for, plaque modification?
Actually, the main idea behind this low speed in the original research that was done in May 2019, the main idea was that with only low speed, there's issue with only when we start with low speed, the ability to pass the lesion may be difficult with low speed. So what they did in the study was to start with high speed so that you can cross the lesion, and then you use low speed in order to modify the plaque. In a context that when you use low speed, the rotor burr actually doesn't just rotate; it bangs on the lesions, the calcium plaques, and resulting in a larger lumen diameter. So that was the idea behind. So thank you for your question.
Okay.
Thank you.
Thank you for your very nice result, Dr. Guang. Can I ask
please.
one question? Yeah. It's very impressive and very informative. One thing that I know is, so based upon your result and insight, can you recommend a routine 2-time rotor operating low and low following high speed? That can be a default strategy for your center?
Yes. In fact, after this study and when we were collecting our data, so my consultant and most of us in the center, we prefer to go for high speed first and then to a low speed, especially when it involves the lesion, different size of lesions, because you cannot, because of the financial implications of using 2 burrs in one patient, that's going to be enormous. So when you plan to gain a larger lumen with one burr of that standard size is 1.5 millimeter, and with that you can actually gain a larger lumen. That was the idea.
Thank you. Do you have any additional concern for additional atherectomy the second time? Any concern of safety? Even there is a low speed,
Yeah. So with low speed, the initial concern was the passing of the burr to the distal lesion. That was our initial concern. And one of the concern was that the debris created with low speed may be larger than the high speed debris. So we were anticipating that this could cause no reflow or distal embolization, and this was our hypothesis initially. So we're looking at that, looking at the pre-procedure myocardial infarction. Yes. Thank you.
Okay. Yeah.
Thank you, Gurang. Thank you, Gurang, for your nice presentation. But when you passing through the lesion with low speed, it is very much possible. It will take the time. The procedure time will be high. And low speed and high speed, for further plaque modification with low speed, I think there should be other tools should be used for complete revascularizations, I think. Thank you. Thank you very much.
Yes,
thank you very much, Gurang. With this, with the constraint of time, we move to the next presentation. That is, I think, is biodegradable polymer sirolimus eluting stent in patients with left main coronary artery disease. The pre-combat 5 trial that is being presented by Dr. Lee. I invite you to present your presentation.
Let me start my presentation. I'm Jino Lee from the Assam Medical Center in Korea. My title is Biodegradable Polymer Sirolimus Eluting Stent in Patient with Left Main Coronary Artery Disease. First, I have no conflict of interest related to this presentation. In unprotected left main coronary artery, second generation DES show a similar clinical outcome compared with CABG or first generation DES. But durable polymer that using in second generation DES have potentially causing stent thrombosis and restenosis. So to overcome this limitation, biodegradable polymer has been introduced. In this study, we evaluate the safety and efficacy biodegradable polymer sirolimus eluting ocean stent in the treatment of unprotected left main coronary artery stenosis. This study designed multi-center, investigator-initiated, open-label, and prospective registry. Patients were enrolled between March 2014 to July 2021. Unprotected left main stenosis over 50% in coronary angiography and treated by biodegradable polymer sirolimus eluting stent. And the primary outcome was 1 year rate of major adverse cardiac or cerebrovascular events that define composite of all-cause death, myocardial infarction, stroke, and target vessel revascularization. Baseline characteristics and clinical outcome were compared with the historical control from the pre-combat 2 or 3 population that using an everolimus eluting stent, that are Giants and Promus, and adjusted with professed score matching method. This is results slide and showed baseline characteristics. Total 157 patients of the treated by sirolimus eluting stent and 791 patients of treated by everolimus eluting stent. The male sex and dyslipidemia, the history of a previous PCI and chronic renal disease was higher in sirolimus stent group. The figure was to show the primary outcome. The left figure showed 1 year event of MACE, and 2 groups show no statistically difference in MACE with the p-value 0.08. So to the composite of death, MI or stroke showed a similar outcome. Each clinical outcome and hazard ratio showed no significant difference between 2 groups. And the adjusted by propensity score matching, this table should match baseline characteristics. After propensity score matching, the 2 groups were distributed relatively evenly, each 157 of patients treated by each stent. The primary outcome shown in the figure A at the left, 7.6 of MACE in everolimus eluting stent and 6.3% of sirolimus eluting stent, and have no significant difference between two groups. And the composite of death, MI or stroke showed 4.5 of each stent group with over 0.99 of the p-value. This is a clinical outcome of hazard ratio in matched population. MACE event showed 6.3% versus 7.6%. And death MI stroke and each 4.5%, and each component show not differ between two groups, and also adjusted hazard ratio showed no statistical significance. This is a limitation. So this study has some limitation, that's a single arm registry and small number, and the time difference with this control group with the case group. But no comparison of the procedural data have some limitation of this study. This is conclusion. In the multi-center prospective real-world pre-combat 5 registry, the sirolimus eluting stent with biodegradable polymer showed a comparable 1-year risk of the MACE event for unprotected left main coronary artery PCI with the second generation everolimus eluting stent. Thank you for your attention.
Thank you very much for your comparative data comparing the bioabsorbable polymer with the sirolimus and everolimus strands. And what I find in this study is it is although it is a multi-centric trial, but it's just like an observational study, nothing was randomized. We cannot take any conclusions, but it is an assurity that the results are comparable, that even the sirolimus eluting and the everolimus eluting stents, the results are almost comparable. And the newer bioabsorbable stent devices now are in vogue, and maybe with new data coming, they might be the new product which can like change our the way of putting stents. And any other questions from any panel?
Thank you, Lee, for your nice presentation. But we know the left main structure is different. The radial strength is high. The Orsiro is a 3-star stent. Sirolimus eluting 3-star stent. Why we chose any? Is there any change in radial strength or other follow-up check angiogram for seeing there is stenosis in left main over the everolimus eluting stent? Those who are high radial stent. As the left main stent, we always thought that the radial stent should be high, and to change in recoil, vascular recoil tendency could not be changed. So I think how many of your patients have been put on recheck angiogram?
Less than 50% of the patient, and so follow-up in the duration, and maybe
is there any follow-up data for your patients that Orsiro is a very thin stent and less visible stent? I know the less visible stent. Usually, though, left main always we do with the IVAS, so the landing zone might be the appropriate. But in follow-up study, the Orsiro stent is a 3-star stent, less radial stent. In left main, we always use the high radial stent. For as we know, the elastic recoil tendency is higher in left main stent. Left main. Have you any comparative data with others in Orsiro? Orsiro stent.
The data, the approximately.
I think
okay.
the most important point in putting left main stent is the expansibility of the stent.
Yes.
We should know the limit where till how much we can expand the stent. The most important point is we should take the stents which, like if we are using a 3.5 stent or a 4 stent, how much is the expansibility of the stent so that we don't deform the stent while deploying that stent. So the most important, as far as I know, I can't say with the certainty, but as far as my knowledge goes, the Osteo stent is a good stent for left main stenting because it has got a good expansibility. We can make a 3.5 stent into 5, we can post dilate it to 5.5. So that gives a good expansion without disturbing the stress of the stent. That's my take. I think the next topic is the impact of cylinder DCA. The presenter will be from Japan, Dr. Yasuda. I invite him to give his presentation.
I'm greatly honored to present my slide here. I'm Nao Yasuda from Nagoya Eisaikai Hospital, Japan. My presentation today is about the impact of cylinder DCA. I have nothing to declare here. This is the history of DCA. DCA was first approved in 1992. After several years, Revival DCA was approved in Japan in 2015. As you know well, DCA have cutter for plug and balloon system at opposite side. If balloon inflation performed, cutter will attach more into coronary plug. This is a video of DCA. DCA is compatible for 7 French guiding catheter. However, it is difficult to obtain good angiography because of busy lumen. It is not clear to perform DCA via radial artery, since we assessed short-term clinical outcome of radial DCA. In our institution, among July 2018 to December 2020, 8 French approach was performed for 201 cases. However, case without DCA, CTO, more than 2 meter rotor ablation were 65 cases, 32%. Moreover, in the 65 cases, around 14% had puncture site complication, as for shoot aneurysm or transfusion due to bleedings. This study was single-center retrospective. Total 130 patients who received DCA from July 2018 to December 2020 in Eisaikai Hospital were enrolled and divided into 2 groups, 7 French radial approach or 8 French femoral approach. And we assessed patient characteristics, lesion characteristics, procedure characteristics, and complications. When we performed 7 French radial DCA, we inserted another 3 French glides for distal radial or brachial artery for angiography like this. We call it samurai style. This slide showed patient characteristics. There were no differences between 2 groups, except for OMI percentage. This slide showed laboratory findings, which also showed no differences between 2 groups, except for HDL cholesterol. This slide showed medication, which also showed no differences between two groups, except for ezetimibe or nitroglycerin. This slide showed lesion characteristics. Pre-percent plaque area and post-procedure percent plaque area were similar in two groups. This slide showed procedural characteristics. In the case of combination with rotablator, full size of rotablator was larger in 8 French femoral approach. Contrast dye was smaller in 7 French radial approach compared to 8 French femoral approach. Finally, this slide showed complication. 7 French radial approach showed no puncture complication. In my conclusion, radial DCA had the same IVUS findings as femoral DCA. Radial DCA had potential to reduce total amount of contrast dye. After DCA, radial DCA had no puncture site complication. Thank you for your kind attention.
Thank you very much for this presentation on DCA and the approach we used during this procedure. It is a well-known fact that in many trials that the radial approach always have an edge over femoral approach in reducing the complications. And in few studies, if I remember, the radial approach also reduces the mortality, especially in acute patients. And in chronic patients, like where we are doing DCA, you have depicted that very nicely, that using cylinder sheath, a cylinder approach that can reduce the at least contrast load and probably fewer complications. With these remarks, I would invite our panelists to discuss.
Thank you. Very interesting presentations. I just want to know, why not use 7 French for femoral? Is it a particular reason that you use 8 French for the femoral approach?
8 French, many circumflex use 8 French.
Because I think that if 7 French can perform the procedure, why not use 7 French? And you'll be more comparable if a 7 French transfemoral compared with 7 French transradial.
This is Tak Matsuda from the Nagoya Executive Hospital, and I'm a co-author of the Nagoya Yasuda. And so, generally speaking, the 8 French femoral approach is common in the DCA because the cast die is very bulky. So if the 8 French, if the 7 French was used, the no dye will be injected from the
for the ease of the procedure.
So in the DCA procedure, the lesion developing for the only specific lesion is very important. So the cutter location is quite we have to care about it. So the angiography is very important during the procedure.
I see. Thank you.
So the 7 French is only 7 French is not enough. So.
But now you show that 7 French is okay.
Yeah.
Okay. Thank you.
So we now move on to the next session. That is also the presenter is from Japan, Dr. Tasuda. The topic will be the major differences between diamond back and rotablator, the aspects from the bench test. I would invite Dr. Tasuda to please.
I'm greatly honored to present my slide here. I'm Tak Matsuda from Nagoya Qca Hospital, Japan. My presentation today is about the major differences between Temnebach and rotabrator. I have nothing to declare here. This is the history of OS. Temnebach was first approved in US in 2013. It was also approved in Japan in 2017. As you know well, the OS system has some component itself. And the rotation speed have two types, slow and fast. Rotation speed of slow was 80,000 RPM, and that of fast is 120,000 RPM. Therefore, the faster the rotation speed becomes, the larger lumen we obtain. However, we sometimes experience the unpredictable debarking effect by OAS. This is the typical case of the unpredictable one. So case 1 have proximal LD region with wire bias attaching to the circumflex side. And the second case have a mid LD region with a wire bias attaching to the first diagonal branch side. After OS, case 1 showed the unpreferable outcome of the intimal damage in circumflex side. On the other hand, the case 2 showed the preferable debarking effect in the opposite side of the first diagonal branch. Originally, in some cases, the debarking effect of the OS corresponds to the Y bias. However, in some cases, the debarking effect is difficult to be guessed. So we examined the OS bench test. We used bending pressed model like this. We performed the OS by pushing and rotabrator. Then imaging study was performed after each procedure like this. So cross-sectional image was assessed in 5 mm length by both IVAS and OCT. Then IVAS and OCT was co-registered for the spatial orientation. Every cross-sectional image was oriented upper side as outer side of the best curve. Typical image of rotor is like here, so very round and was obtained. However, both pushing OS and pull OS have orbital lumen gain like this. So the roundness and the lumen area was shown here. So roundness of push OS was deteriorated compared to the pull OS or rotabrator. However, lumen area of push OS had larger lumen compared to the pushing OS. They were statistically significant. So this is a typical image of the each debarking effect obtained. The pull OS abrade inner side of the vessel course like this. However, abrasion by rotabrator was quite correlated to the previous guide wire. And push OS abrade outer side of the vessel course like this. And abrasion by rotabrator is also quite correlated to the previous guide wire bias. So assessing the angulation between wire bias and the abrasion site, rotor have 21 degree of angulation. However, the push OS and the pull OS have almost 19 degree of the angulation. In other words, the rotor works quite bright manner. There was significantly statistically significant. So plotting each debarking site obtained, the rotabrator abrade multiple sides of vessel like this. However, pull OS limited mainly to inner side of the vessel. However, push OS limited mainly to the outer side of the vessel curve. So my conclusion from bench test shown here, the working effect of rotablator was corresponding to the previous guide wire bias. However, that OS was irrelevant to the pre-guide wire bias in bending model. Pull OS ablate inner side and push OS ablate outside of the vessel and read over lumen area. Thank you for the kind attention.
Thank you very much for your nice presentation. We have seen whenever we do atherectomy in your clinical practice, there are some biases which come into play, and they like the wire bias you have discussed in your topic, and the benchmark testing is really a good method to evaluate our clinical practice in interventional cardiology. A lot of information can be gained from the benchmark testing, as we have seen in your study also, that how we can reduce the wire bias, and also for complete atherectomy, pushing, pulling is important. Even in models like where we see bifurcation stenting and other models of complications, benchmark testing has been found to be very useful, informative, and gives us the hypothesis which can be like applied to the clinical practice. So with these remarks, I would like to invite panelists to say something and any questions, queries.
So thank you. Very interesting presentation. So I just want to know, how do you decide? You mean, I mean, in the in vivo case, in real life patients. So is it really easy to differentiate which side is the inner side or outer side based on the OCT or IFS?
Yeah, it's a very important question. So if doing the IGOS, we can see the guide wire bias. So it's the same as the TCTAP procedure. We have to orientate the guide wire and the guide IBS caster with the very close side. So we can rotate the IBS from the IBS image to the how can I say it? I can really differentiate the which angle we can see from 12 o'clock or 8 o'clock, because the IBS caster and the guide wire like this. Yeah. Then the same side like this. So after that we can, yeah, we can know about the exact direction from the where to I can see. It's the same as the OCT.
So actually, this was a nice session attended by all learned personalities, and actually we really had a good discussion, and the comments by the panelists were really absorbing and interesting. The topics which we studied today, right from the ECG topic, and then the scores, and then the main topics on orbital atherectomy, benchmark testing, DCA, and even the drug-eluting stents, bioauxiliary absorbable. This session was really absorbing and knowledgeable. I thank you all for attending this session patiently and delivering your knowledge. Thank you so much. Thank you, and have a good day. Thank you very much.
Thank you.
Thank you. Thank you. Thank you. Thank you very much.